Dr. Sharad Bhomaj unfortunately lost his dad. I'm extremely sorry about that. May God give peace and Godspeed to the departed soul. So, in place of him, I will just present, you know, the top. So he was supposed to talk about a wide ILM peeling for large full thickness macular holes. Definition wise, a large macular hole would be anything above 400 microns. Conventional ILM peeling would be about 2 disc diameters around, and a wide one would be up to the arcades. The advantage of conventional peeling would be better post-operative macular hole contour and higher incidence of type 1 closure compared to the ILM flap techniques, and it is easier as compared to ILM flaps. If we look at the natural history of PVD occurrence as well as how a macular hole gets formed, so there are two elements to it. One is the antero-posterior traction and the other is the tangential traction. Now, in a scenario, typically whenever it's just the antero-posterior traction predominating, the holes which get formed are tiny ones. It is only when the tangential traction component takes over and is predominant that the hole progressively becomes large. So you have a pull going on in horizontally as well as vertically, and unless this is relieved, we are not going to be able to close the hole. So a wider ILM peel ensures greater relief of tangential traction and more complete clearance of the hyalinized pathological ILM and the vitreous cells which are remaining over there and are metamorphosed into fibroblasts and fibrocytes. So once all this is removed, there are greater chances of closure. Like here you see a large macular hole initially under a silicone oil tamponade. It's undergone a type 2 closure, and eventually it goes ahead and becomes a type 1 closure. So the edges can actually oppose eventually. Besides, there is no stuffing or graft, so scarless or relatively scarless healing, minimal thinning, and maximum visual potential. So here you see different types of holes with different types of peeling and flap being done. So you have these kinds of depressions or these lines of joining which are not there in a typical type 1 closure. And whenever those lines are not there, obviously visual return is better. So the advantages of wide ILM peeling, they far outweigh potential side effects which may not be clinically relevant, and the main disadvantage would be harvesting ILM for revision surgery. Okay, so where free ILM flap obtained from a different area would have its own challenges. So to overcome this, one can still do a wide ILM peel, but leave behind an island of ILM in a nearby area, so that can still be taken as a hinged flap should it be required in a subsequent surgery. So I feel that a wide ILM peel is the best option for large macular holes for primary surgery. Thank you.
I think we'll take questions.